My topic was supposed to be on designing a research study, formulating the question, and it's going to be largely revision for those who I think everyone was here yesterday. 3/4 of what I was to talk has been covered. So what I'm going to do is revise that and only make a few points, which means that you'll be rid of me faster. The additional caveat is I hope Swapnil Hiramat never reads any of my papers. So every day in the clinic, we are forced to ask ourselves questions and take clinical decisions. That's on average, we take, it's said, 2 clinical decisions on every outpatient and about 5 decisions on inpatients. So for instance, everybody yesterday also started with, it's a case that is in front and we want an answer. So 50-year-old diabetic for 8 years, trace protein on dipstick comes with swelling on the feet and a creatinine of 1.8. We could ask ourselves unstructured questions when the patient is in front of, is this diabetic kidney disease? That's an unstructured question. Are there different, what are the differentials? What is the mechanism of raised creatinine without proteinuria? Should I do a kidney biopsy, check the fundus, and should I start an ACE inhibitor? If I make this into a structured question to do a study, I would ask, is a patient without proteinuria or retinopathy likely to have diabetic kidney disease? So what are the chances of that? I want to quantitate the possibility that this patient has diabetic kidney disease. Does that possibility justify my doing a kidney biopsy in the patient? Are there benefits of ACE inhibitors? And if there are, do they outweigh the risk? Now, one thing is that if I could get all these answers to my questions from the literature, then there's no point in deciding a study, in planning a study. So if the literature contains the answers, and Swapnil mentioned that, and the Cochrane reviews or even today the Lancet, they have a short box at the start of an article saying, what does this study add to available information? So that's something that I ought to ask myself before I start planning a study. Am I going to add anything, or is everything, that often happens with theses, that, and then when we are, why do you want to do this study? It hasn't been done in India. Well, are Indians different every time? If they are, certainly it's worth doing it. Though the ideas for a study might come from the patients we see, from reading literature, from conference lectures, which might suddenly trigger off an idea. Having got an idea, and at the end, as Sanat said, what we're going to do is, there's a small number only, we're going to distribute some ideas and see if we can, from those ideas, generate a hypothesis, ask a question, and then design a study to answer that question. For instance, this is an example. If we have a hypothesis, remdesivir lowers mortality in COVID-19. So we are trying to prove an association between a remdesivir, a set of patients who received remdesivir, that they have a lower risk of dying compared to placebo or standard of care. To do that, we assume that there is no difference, and we call that a null hypothesis. So null, no difference. That remdesivir and placebo have an equal mortality in COVID-19. And then we try to disprove that null hypothesis within a certain confidence. We want to have some confidence that we should reject that hypothesis, that there is no difference. Having rejected that null hypothesis with 95% confidence, we are left with not one, but 2 alternate hypotheses, as I said yesterday. Remdesivir has less mortality than placebo, or placebo has less mortality than remdesivir. Both are possible, and even today statistical packages like NCSS will throw out the probability of the null for the rejecting the null hypothesis, as well as the probability of each of the other 2 hypotheses. So here's a set of ideas. So in patients with COVID-19, with ARDS, with cytokine storm, will using a cytokine adsorbing device like Cytosorb lower the risk of dying compared with not using it? In patients whom we dialyze with permcats, would using urokinase instead of heparin or trisodium citrate lower the incidence of catheter dysfunction? As AKI, with patients with AKI and fluid overload have higher mortality, then ultrafiltration with renal replacement therapy will lower the risk of dying, shorten the ventilation period and the ICU stay. Many Indian patients with MHD patients are malnourished, so one-on-one dietary counseling will improve nutrition and quality of life. So these are just some ideas I have thrown in. We then go to the next step. search the literature to determine the need. If the questions that I asked have already been answered in the literature with, of course, all the cynicism which Swapnil mentioned, we can look at the literature with that cynicism. And in many places, prior to starting a study, it's mandatory in many institutes to do for the student to do a meta-analysis first. Formulate a research hypothesis. So we refine, add focus, add objectivity, define our hypothesis, design the study to give unbiased results, collect and enter the data, analyze the data, and then either publish it or present it. Yesterday there was a lot of talk on you must even publish case reports. We must even publish small case series because at least they would generate hypothesis for newer studies. So this is something known as, which was not covered till now, and that is the finer criteria for a research study. That is the feasibility, the interest in a study, how novel is it, the novelty, is it ethical? Manish Rathi gave an excellent talk on all the aspects of ethics of the research, and is it relevant either to scientific knowledge, to formulating policy, or to future research. So feasible, that should be adequate number. Dr. Srijit talked about, I would face the same situation. Our hospital does 15 to 20 transplants a year on average. So if I calculated that I would need to study 200 transplant patients in a study, it would take me 10 years and probably I would run out of interest and time before that and I wouldn't complete the study. Technical expertise. If I want to do a study on proteomics in say glomerular diseases, I don't know anything about proteomics. So if I don't have the technical expertise, I either cannot do the study or I need to get in a technical expert to help me. Affordable. There was a huge discussion towards the end of yesterday on grants for research, and what emerged is, yes, the grants, the money is available. We need to be able to apply for it, and one of the things about applying for it is to plan a decent quality study to do it. And is it manageable? Do I have the manpower? Do I have the time? All of these things to do a particular study. Making it interesting. So here are some studies I picked very recently published. So clinical characteristic and outcome of NEL1 associated membranous nephropathy. So today I might find this interesting because on a kidney biopsy I can get an IHC done for NEL1. So I might pick NEL1 membranous nephropathy, and I would therefore like to know if somebody has already described the characteristics and outcome. A novel antibiotic targeting the lipopolysaccharide transporter, Nature of January 24. So we are all interested in antibiotics. We are all faced with antibiotic resistance. So this study would interest me. Ultrafiltration rate and mortality, yes, both of those. Lecanemab in early Alzheimer's disease. Not very interesting perhaps to nephrologists unless we have relatives who have Alzheimer's disease. Then it might interest. Treatment strategy for rifampicin sensitive, it doesn't interest me. The title itself, we are facing problems in India with rifampicin resistance. So somebody trying to give me a strategy for rifampicin sensitive, I have been doing it for 30 years. Is lactated ringers superior to normal saline? This is an example of what Dr. Nitya talked about yesterday. The authors will make us read this study because they haven't told us the result. They are asking a question in the title, NEJM 2023. We'll have to read the study if we want to know whether it's superior. If the study had been reworded, lactated ringers is superior to normal saline in acute pancreatitis, I would have the answer. I would decide that, okay, I'm going to start using ringer lactate. I'm not going to read the study. Lower mortality in patients treated with hydrocortisone for community interests me. There should be novelty about the study. So here are some studies. Use of interleukin 6 receptor antibodies in the second and third trimester of a retrospective cohort study. Yes, it's novel because usually pregnant patients are excluded from the study. So here's a study that's looking at the safety of a drug which may be required to be given to these patients. 2 dose levels of once weekly fosravuconazole. So a new antifungal drug which you can give once weekly compared with the daily drugs. But this study is coming from Sudan in eumycetoma. So what Swapnil was saying a few minutes ago, it may not be applicable to other fungal infections. It may not be applicable to India. propulsion system design for the Indonesian semi-high speed train. Well, it's novel because it's something new. And the last one is from 130 novel electronic projects. It's novel because what this author did was he found that his children were watching too much TV and he couldn't control it because he wasn't at home. So using the timer IC 555, he designed a small circuit which was about 4 by 3 inches in size, placed on the top of the TV, which used to jam the remote, so that they couldn't put on the TV from a particular time from when they returned home from school till when he returned home from work. And then he went on to do a study in which he lent it to his friends and he collected the data, and now he's given us the circuit in this paper. What's the relevance of a study? I treat ANCA-associated vasculitis all the time. So a study like this, rituximab versus cyclophosphamide, is relevant to me when I want to. On the other hand, FOXP3 exon 2 controls Treg stability and autoimmunity. I don't even understand the terms. I don't know what's FOXP3. So that study may not be relevant to me. Effect of dialysis dose and membrane flux? Yes, it's relevant. The next one is again not. Genome-wide CRISPR screen identifies phospholipids. KI May 2024. Scramblase 3 in the biological target of mitoprotective drug SS31. I don't know what it means. Global trends of acidity in rainfall and its impact on plants and soil is relevant to everybody, because acid rain and climate change are relevant to all of us and we ought to be doing. Quantum field theory for spin operator of the photon. I don't again understand what it's saying. Now this is a study, a multinational multi-center study mapping models of, the first author is Nivedita Kamath from St. John's Medical College, Bangalore. Now it would be relevant even to healthcare providers and maybe healthcare policy makers, because what this study does is it talks about kidney supportive care models. Meteorological and traffic effects on air pollutants, maybe, maybe not, Journal of Environmental. Organic amine pesticides in drinking water health risk assessment of the Yangtze River comes from China. Now, unless our rivers are similarly being polluted, and most probably they are polluted by pesticides, then this study would be relevant to us. A detailed study of dwarf galaxies in the core, this Journal of Astrophysics and Astronomy, maybe, maybe not relevant, only if you are interested in that. And then there are 3 more from 130 novel electronic projects, a journal which I read sometimes. The third one is relevant. Simple water level sensor or liquid level detector are the secondary air deaeration chamber of our dialysis machines. You will be seeing on your dialysis machines, you get an alarm, level sensor failure sometimes. So that's because there is a level sensor which is supposed to trigger the air separation pump on the dialysis side of your dialysis machine. So that was relevant to me, and so I read the study. That brings me to the Picot question. The complete is Picotes. So yesterday a lot of talk on patient, population, problem, interventions, comparisons, outcomes. Additionally, it includes the time frame for measuring the outcome. Now the time frame is not the study period in which the study was done. So it's not I start a study in 2024 and it is till 2026. It is the time frame. So if I'm measuring 1 year mortality or 30-day mortality, that's the time frame for measuring the outcome. The outcome is mortality and the time frame is either 30 days or 1 year, or if the study. There was a lot of talk on effect size. We didn't exactly talk about effect size, but we saw how it entered into many of the discussions, and then there is the study design. So this is essentially what I'm going to go over fast because it was covered, that researchers use samples to know about populations. What we try to do is to draw a small sample from a population, define the values in the sample and extrapolate that to the population. So just now we have a lot of disgruntled NEET students across the country. So if the government wanted to know what the students feel about NEET, the population is 3 lakh students and it's too large and geographically dispersed. So they might draw a sample of NEET students, get their opinions about the NEET exam and come to know. Quality control. A factory which is making dialyzers or double lumen catheters doesn't test every one of the 10,000 dialyzers that they produce. They draw a sample for quality control and they look at those, they test those, and they give us a specification sheet saying this is how the dialyzer will perform under these conditions. So medical researchers, the commonest one, will take a small sample, give a new drug to that and try to extrapolate that. Opinion and exit polls. So the total number of voters in India is about 100 crore probably. So what the exit polls did was they looked at about 5 lakh and they still got it wrong. So and there were reasons for that. Which later were analyzed, that it's more of people who tend to answer internet questions, who tend to use smartphones are the ones who answered the exit polls. Not all. The rural people didn't. So population parameters are precise, but we don't know them. So what's defined as a variable in the population is a parameter and it is fixed, but we don't know that value. Samples estimate the value in a sample and extrapolate that to the population. The estimate will never equal the parameter exactly. There is some margin of error which we try to minimize based on our sample size and effect size, and there are some methods of doing that. So yesterday there was a lot of discussion on sample size. Should we calculate sample size or should we not? There are reasons for that. And the sample size, finally, the sample size that we calculate may be wrong. Here are 3 trials, IVORE, IDEAL-ICU and Euphrates, all of which got it wrong. So in IVORE, what they did was, they were looking at high volume hemofiltration in critically ill patients with AKI. They said the mortality in the control group is 60%. We are going to try to reduce that to 48%, that is a 20% relative risk and a 12% absolute risk with high volume hemofiltration, and they calculate they would need 460 patients to have a 90% power in the study. Now what happened was, at the end of 140 patients, they found that the mortality in the control group was 41%, way below what they had assumed, and that in the test group it was 38%, so the difference was just 3%, and they abandoned this study after 5 years of recruiting 140 patients for futility. IDEAL-ICU did pretty much the same thing, as did Compact 1. So how good is our sample to extrapolate the results depends on inclusion and exclusion criteria. The tighter the inclusion criteria, less is the generalizability. So the more inclusion criteria we make, lower is the generalization. If we do a study in patients who are more than 18 years old, it doesn't apply to patients to the pediatric population. It may be true, but this study doesn't tell us that. So these are from IDEAL-ICU. First 48 hours of septic shock developing AKI with at least the failure stage. Another mistake that's often made is inclusion criteria age greater than 18 years, exclusion criteria age less than 18 years. It's not true. An exclusion criteria means this patient would fulfill the inclusion criteria, but for some other reason needs to be excluded. So either he's going to die before 48 hours or he's going to die within 7 days, and our outcome is to be measured at 30 days. So that's the reason the patient is going to be excluded. Not because he should, to fulfill an exclusion criteria, the patient should first fulfill all the inclusion criteria, and therefore they are not to be opposite of each other. And this is what Swapnil was also saying, and this is taken from IDEAL-ICU. 3,500 patients were screened and only 488 ultimately underwent randomization. So this is the difficulty with sample sizes when calculated, and the number that needs to be screened is most of the time much larger. He pointed out it's usually you end up with 20 to 30% getting in. So that was about the patient population. Now the intervention. So we need to define, and what's done these days is that the methods are not dumped, but put into a supplementary appendix, because the editors of a journal will rarely ask us to cut down on methods. They will ask you to cut the results down, reduce the number of tables, etc., or they'll push that also into the supplementary appendix, but they won't ask us to cut down methods because we need to describe the methods in full, because that determines the validity of the study. Using a faulty methodology is going to give faulty results. So this is from the renal study. Look at how well the authors have. The patients in both groups were treated with CVV-HDF. 1:1 ratio of dialysate and replacement. They used AN69 filters. They've told us which filter they were using, which fluid they were using. The only difference between the intervention and the control group is one received 40 ml per kg per hour and the other 25 ml per kg per hour. How much blood flow they kept, how they removed fluid, everything described in great detail. This is start AKI, which Swapnil was on. Once again, They've told us how they did the randomization, what block size they used, what stratification they did. The only difference is between the intervention and the control group. And then they've said the standard group is not obliged to receive RRT. So very precise, very extensive methodology descriptions are necessary. We need to define all the terms that are used. So this is from my own SLED study. Hypotension during SLED, different people would have different definitions. So I had to define it as drop in mean arterial pressure of 10 or stopping ultrafiltration and need to give a saline bolus or increasing the noradrenaline dose or an absolute mean arterial pressure of less than 60. Yesterday Dr. Nitesh showed us a study where nothing was defined. Everything was you go and read this study. Inotrope score as per so and so study. Vasopressor dependency index as per this description. But most of the time we would describe what we are using. So levels of evidence again was described yesterday. So these are the 5 generally accepted levels of evidence. Sometimes they say there are 3 additional ones. So level 6 is in my series of X cases never published, it was like this. Level 7, I remember in one case, in level 8, this is the way I do it and it's the best. Right. So coming back to the Picote's question, why sample size? Now this is from Harvey Motolsky's book, Intuitive Biostatistics, a non-mathematical approach, a book which I find very useful. What he says is that researchers started with a study in 5 patients in each group and they looked at a p-value, they plotted sample size on the x-axis and p-value on the y-axis. At the end of 5 the p-value is nearly 1. Then they went on to 10 patients. At the end of 10, it's still the p-value is very high. 15 patients. At 20 patients, the p-value became 0.06. At 25 patients, it became 0.03. 30 patients, it's some 0.02. And then it started to go up again. So at 75, again it was not significant. But this study would not get completed. As soon as they reached here with 25 to 30 patients in each group, they would have probably stopped the study. And that's what happens to all of us. When we were doing the SLED study, with the first analysis after 29 patients, no. 55 patients, oh, it's come. The 95% confidence is less than 1. SLED works. So that's what could happen if we don't a priori decide the sample size and we decide at that time what sample size we have chosen and why we have chosen it. So this again what Harvey Motolsky says, sample size is the result of a negotiation between the difference, that's the effect size, that we are prepared to accept, the significance level that we have chosen, that's the alpha error, the desired power, so the beta error, and the number of subjects it is possible to enroll. So we have to decide all of those. If you choose a very large sample size, any difference will come statistically significant. So this is the all-hat trial. 33,000 patients. At baseline, the systolic blood pressure was 146 plus minus 15. They randomized the patients to chlorthalidone, amlodipine or lisinopril. Now look at 4 years, the systolic blood pressure in the CTD group is 133.9. In the amlodipine group it is 134.8 and in lisinopril it's 135.5. So blood pressure lowering in all. So then they did 2 group comparison. So CTD versus amlodipine lowering is 12.3 versus 11.4 mm. P is equal to 0.002. Can you measure a difference of 0.9 millimeters of mercury, which is the difference between CTD and amlodipine? And for lisinopril it is about 1.1 millimeters of mercury. And yet everybody who makes chlorthalidone will come and tell us, Doctor, chlorthalidone in all-hat was shown to be superior to amlodipine and lisinopril. So this is an absurd effect size which is not measurable, and in the Hygia trial which he was showing, I saw the same thing. The LDL cholesterol, which was statistically significantly different with in that, was 120 versus 118. So a difference of 2, which a laboratory probably cannot pick. You do the same sample twice and it comes. So when you choose large numbers, small differences or small effects start to look significant. So this is what, or the other thing is, as I said, a wrong estimate. So in reverse is early goal-directed therapy. Early goal-directed therapy mortality was 30% versus in the control group it was 46%. Looks great. Absolute risk reduction 16%. Number needed to treat to save 1 additional life, 6 patients. Looks really great. And then 3 much larger studies came out. Process, Promise and Arise, by which time protocols were coming into force all over and they could show no difference. Why? Because Here you see the mortality in the control groups, which in reverse study was 46, has fallen to about 15 to 20%. So as results overall get better, it becomes more difficult to show a difference. So this is ideal ICU. Again, what they did was they told us about interim analysis, that they said mortality in the control group will be 55 and in the treatment group early strategy will be 45. So we calculated that this statement is in the NEJM. 5% of patients will drop out. So we will need 864 patients totally to do a study with 80% power and 95% confidence, and 2 interim efficacy analysis were planned at which they would do it. So that brings us to, when we're doing a study, we can plan an interim analysis, because usually the interim analysis that happen for me is that the student's thesis time is up, it's got to be submitted, I've got to do an interim analysis and it has to be written. But interim analysis can provide an estimate to an opportunity to estimate the sample size. So this was done in the Euphrates trial. They started with a planned sample size of 360, then they found the effect size was not as big as what they were had planned, and they re-estimated the sample size and they terminated the study at 450. An opportunity to modify the study design, an opportunity to stop the trial for efficacy. So the carvedilol in heart failure study, the ethical committee said it's unethical to continue to deprive patients of carvedilol. The results are so good, so they stopped the study. And an option to continue the study as originally planned. So there are some rules. If we go on using the same data and submit it to repeated analysis, we induce, and I think Tukaram showed that yesterday, each time the alpha error increases by 1 minus alpha raised to the number of analysis. That's the formula. So they use very much smaller p-values or alpha for stopping the study at an interim analysis. And there are 3 methods: Pocock's method, Hay-Bittel-Peto method, and O'Brien-Fleming, which is the commonest used. So this is what ideal ICU did, and you can see their statement here. Assuming mortality would be, that's I've already said that, when they actually did at 488 patients, they had planned for 864, they said among the 477 for whom follow-up data at 90 days were available, it was, instead of being 55 and 45, the difference was only 4%. So P was not significant. They said continuing to spend money in a trial that had a little chance of demonstrating efficacy and was undesirable, and they terminated the study. So this is what Dr. Nitya was mentioning yesterday about p-values. This is the American Statistical Association's 2016 statement. I'm not going to go into it because Tukaram talked in detail. Then there was 95% confidence intervals. I want to demonstrate again I've modified the test given in Harvey Motolsky's book for Indian situations. So here are 10 questions. What I want you to do is, in the next couple of minutes, write down the range where you think the right answer for these questions lies, where you are 95% sure that it is where the range lies. So age of Mahatma Gandhi at his assassination, I have modified Martin Luther King to Mahatma Gandhi. Length of the Brahmaputra river in kilometers, the number of countries in SAARC, number of books in the Rig Veda, the diameter of the earth in kilometers, the year in which Mozart was born, seats in an A320 Airbus.
So sir, you want us to write a range, or you
A
want
range.
us to write
No, not the value. A range where you are 95% certain the true value lies. Okay. So these are the answers. So age of, all of us have seen that picture of Mahatma Gandhi as an old man leaning on a stick. So 78. The length of the Brahmaputra river is 2,900 kilometers, 8 countries in SAARC, 10 books. The diameter of the earth is 12,800. Mozart was born in 1756. 180 is what? Sits in an Airbus. 645 days is the gestational period of an elephant. The distance from Mumbai to Delhi by road, before the new expressway comes of course, is 1429, and the depth of the Mariana Trench is 10.9. How many got 9 out of 10?
Range, sir.
Range, exactly. So that is the answer. So if you had picked a range where you were 95% certain, 9 out of 10 should have been correct. But most of the time we are trying to be too precise. So we are trying to get the right answer. Now if the first one, you could have written 10 to 100 and you would have surely got the right answer. But it's of no use. It's useless information because we know that Gandhiji didn't die when he was 10 years old, and we know that hardly anybody lives to 100. So if you said, then you said 50 to 80, you would be much closer. So the 95% confidence interval is something where we want to be 95% certain. The true parameter in the population, we have estimated from a small sample. We're trying to extrapolate and see if we can be 95% certain that our value or that the population value lies within our range. And this, what the exercise tells us, as the author says in the book, is making guesses. We are bad at making guesses. So we need studies for that reason, and we need 95% confidence intervals. Why do we need small 95% confidence? The Olympics are on. So somebody gave me a nice analogy the other day. Imagine you are the captain of the Indian archery team, and there is a tiebreaker shootout for the gold medal. Now you have two shooters whom you can select, both of whom have an average score of 9. You know, the archery, the center is 10 and then you have circle. Both have an average score of 9, but one of them, his 9 comes because he shoots between 8.5 and 9.5. The other gets that because he shoots between 7 and he gets 10 some of the time. Whom will you choose? Why?
He's more accurate.
He is more likely to get you that 9 because it's more precise. The other guy could give you 7 or he could give you 10. So if you are a gambler, you would. And incidentally, the science of probability was invented by a French gambler called Du Bois in a book which he wrote called The Laws of Chance. Right. So 95, that was about 95% confidence interval. There was a fair amount of discussion. Whenever we estimate a 95% confidence interval, what we mean is that if the study we did was repeated 100 times over, then 95% of the time, this is the range in which the true value would lie. 5% it will still be wrong. So all these have been looked at. Why we p-value? I'll just go back to the ideas I threw at the start before I end. In patients with COVID-19, the research, I'm trying to make that idea into a research question. What is the P? COVID-19 patients with acute lung injury, either a CORADS more than 20 out of 25 or a Murray lung injury score of more than 2.5 with an IL-6. In my hospital, the IL-6 normal value is 6 to 50. So I'm keeping more than 150, more than 3 times the upper limit of normal. The intervention, 2 6-hour sessions of hemoperfusion with the cytosop device, 24 hours apart with a blood flow of 100 ml per minute. The control, standard of care with ventilation, remdesivir, dexamethasone and proning as needed. Outcome, 30-day mortality, ICU stay, days of ventilation. Beware of surrogate outcomes. So decrease in IL-6 is a surrogate outcome. And the HICORIS study, which looked at high volume hemofiltration, they showed at the end that 80 ml per kg per hour versus 40 ml, 80 ml reduced the cytokines, but mortality was no different. So I wouldn't like to go to a patient and say, oh, here's a treatment, there are 2 treatments, one costs double the other. There's going to be no difference whether you die either way, but you'll die with lower cytokine levels. So it doesn't make sense to do that. The other thing is composite outcomes. So they say beware of composite outcomes. There was a study called the RITA study, RITA 3, which looked at a composite outcome on cardiovascular of myocardial infarction, death and refractory angina at 3 months, and it was statistically significant. And what they found later was that it was 9.6 versus 14.6%. And why it was driven in that direction by only one of the 3 outcomes. That was the unstable angina. So deaths were the same in both groups. New myocardial infarctions were the same, but the unstable angina was less in the treatment group, and so the composite outcome drove it in one direction. An even worse one was another study on CABG and cariprazine, which they said again, they looked at a composite outcome of deaths and myocardial infarctions, and it looked like, oh, the intervention group is doing better, and then subsequently they found the intervention group had less myocardial infarctions, which was driving it in one direction, but the deaths and strokes were actually significantly higher in the intervention group. So a composite outcome can drive something in one direction by a not so important parameter. Okay, last of all, you can do this with me. Chalo. I threw the idea, patients dialyzing with tunnel cuffed catheters using urokinase instead of heparin or trisodium citrate to lower the incidence of poor flows. What's the question now? We're going to put it in P. Manjunath, not you, yeah. Just hemodialysis patients?
In dialysis patients with tunnel cuff.
Dialyzing with tunnel cuff catheters. You want to specify the number of times per week, or will it not make a difference? If you randomize, it may not make a difference. If you don't randomize, the person doing 3 times a week is going to get more handling of the catheter than the person who's doing 2 times a week. So you'd have to specify depending on your design. Swapnil pointed out that randomization is expected to ensure a uniform playing field. If you haven't randomized properly, then you don't know whether the groups are comparable. Though of course, he said that's why you don't do p-values if you trust your randomization process. So, patients on 3 times a week with internal jugular TCC. Why? Because femorals are anyway more prone to dysfunction. So I'm going to specify that I'm going to study internal jugular TCCs. I'm not specifying right or left, excluding those planned for transplant in 6 months. Because if I'm trying to measure something which may take tunnel cuff dysfunction may happen at 7 months, 8 months, 1 year. And if the patient gets transplanted, a good many patients get transplanted in 6 months, the study will be useless. So I will exclude those who are likely to be transplanted early. Intervention? Yeah. So the intervention is urokinase. I have to define the amount I am going to use and how I am going to do it. So 5,000 units as catheter after each dialysis, or in the actual study which was done, I can't remember the name, it was done in 2016-17, they did once a week urokinase versus heparin the other 2 times. Comparator? Okay. Outcome?
Flow rate, but measure the amount, like less than 300 mils per minute.
But supposing to start with I was not getting 300.
30% drop in flow rate.
Yeah, a percentage drop or the time to which I cannot use the catheter because it gets blocked. So number of sessions with less than 80%, so Sanat said 70%, time from catheter use to reduction in blood flow, or intervention to salvage the catheter, or abandoning of the catheter. So I could choose any, I'll keep one of these which is the most important to me as my primary outcome, and I'll make the rest as secondary outcomes. Time. So time period. So if I have taken time period on this thing of catheter dysfunction, catheter insertion till 1 year after that. And now the effect size. Sorry. Someone should tell me the effect size. What are you prepared to accept? So Sanat said 30%, but that's the outcome. So how much effect are you prepared to accept between urokinase versus heparin? 5% difference, or I'd go and look at the days. So if my catheters are going to dysfunction at 100 days with a standard deviation of 10 days in the control group and increase to 120 days with a standard deviation of 15 days is what? Now the reason for standard deviation is that many sample size calculators will ask you for not just mean but standard deviation. The reason for that is, again, Harvey Motolsky gives what he says this is a silly example, but it demonstrates how you got to go about it. You ask somebody to go to a room and fetch something from there. If he comes back in 5 minutes versus he comes back in half an hour, when is he more likely to find what you asked him to bring? The longer. So longer is equal to sample size. The more time taken is analogous to the sample size. If you ask him to find a watchmaker screwdriver versus a hockey stick, which is he more likely to pick? The hockey stick. It's larger. So the effect size is analogous to the size of the tool that he's searching for. Bigger the effect size, more likely are you to find it. And if you ask him to search for it in one of these hotel rooms versus the garage at home, when is he more likely to find it? In the garage. Why?
More likely to find it.
Why?
Such is.
The garage is a big mess. Everything that I don't want is dumped there. So the more tidy your data is, the less variability, the more likely you are to find. So sample size calculators ask therefore for the standard deviation, which is, or the standard error of the mean, which is a measure of the variability of the data. So, setting randomized control study, I went to OpenEpi 3.3 and I did this calculation. So what it told me is if I want 95% confidence and 80% power, then 10 patients in each group is good enough to detect this. So 30 patients totally. So then I said, oh, but am I going to spend for urokinase, which is about 850 rupees versus heparin, which is 120 rupees. So let me have more confidence. So I went to 99% confidence and 90% power, and then I got 26 patients in each group, which is still doable. I'll stop over here.